So that means when you get this stuff sticking to the walls, it can become very jagged. And so if it breaks loose, then you're going to have other things coming there, such as your wonderful platelets that can cause a blood clot. So that can cause a problem for the patient and cause either a partial or a total occlusion, and the patient could have ischemia, or they could actually have a myocardial infarction. So this slide here pretty much tells you what we just talked about, because we said that cholesterol and fat pretty much will just kind of circulate in the blood, and then it has started adhering to the arterial wall. All right, and if it breaks loose because of the turbulent blood flow and because it is very jagged, it can cause damage and cause platelets to actually come to the area and cause that blood clot. But just the fatty buildup by itself is going to narrow the arterial wall. So kind of keep that in mind, that area is going to get narrow even with just cholesterol building up there. So the patient can become ischemic, and that might be what brings them into the doctor's office. But more than likely, a lot of times that when you go into the doctor's office, atherosclerosis is found incidentally, because they start testing your cholesterol levels as you get older, like 45 to 50. And then, of course, if you've got heart disease in your family, or if you're hypertensive, they're looking at that all the time and wanting to control it all the time. So here it is again, where I said you'll have a blood clot that forms, and it can occlude the artery, or it can break loose and cause other problems and move elsewhere. And like I said, it can cause either a partial or a complete blockage of the artery. All right, so let's look at some things that put patients at risk for cardiovascular disease. Some of these are modifiable things. They're going to be very similar to hypertension. So let's look at these. Let's select all that apply. Do you think age is going to play a factor into your arterial sclerosis? When does it start developing?
In childhood.
Yeah, in childhood. And then we don't really see it, though, until about 40 or 50 years old. Gender. Would your sex make a difference?
No.
Okay. What about hypertension?
Yes.
Oops, I hit the wrong one. So hypertension will, yes, that's modifiable. They're saying that's a modifiable one, but is age modifiable? No, gender is not modifiable. But we know that men and women are getting closer within a range with heart disease, but that's not modifiable, is it? Is obesity modifiable that can cause you to have cardiovascular disease?
Yes.
Yeah, because I can lose weight. Smoking, is smoking modifiable?
Yes.
Yeah, because a person can cease smoking. So, and let me tell you about smoking. Smoking actually will increase a patient's LDLs. Now, are LDLs good boys or bad boys?
Bad.
Bad. So keep that in mind, that if you smoke, you are increasing your bad LDLs, which are lipid density lipoproteins, lower density lipoproteins. With smoking, you're going to increase those, which are bad. Can you change your sedentary lifestyle?
Yes.
Yes, you can. So those are all modifiable. Those are things we can change that put you at risk, just like anything with hypertension. Now, some other things that you can actually work on too, a patient that has diabetes. We would want to know about diabetes as well, because remember, with your diabetes, your high blood sugar increases the amount of inflammation in the body as well. And also, the higher it is, it's going to affect the scarring in the lumen of the arterial lumen as well. So the non-modifiables, once again, very similar to our hypertension ones, are age, gender. We can't change our sex, our DNA part of our sex. We can physically change the way we look as a male or a female, but you can't change your DNA. Your DNA is always either male or female. Ethnicity, we can't really change that. We are who we are. We are born the way we are. We don't have a choice in that. Most of us don't have a choice in genetic predisposition for hyperlipidemia as well. Now, if you're adopted, you may not know that you have this genetic predisposition for hyperlipidemia unless you do know your birth parents, or maybe your adoptive parents know your birth parents. Then you may know this genetic predisposition. Otherwise, you may not know it until you get in your 40s or 50s and you have a problem with hyperlipidemia, and it's not really related to your ethnicity or any of your lifestyles that are modifiable, because maybe you're not diabetic, maybe you're not overweight, maybe you're not a smoker, maybe you're a very advocate runner every day, but your cholesterol is still high. That could be because it's genetic. Other things that are modifiable, once again, the blood glucose control with your diabetes, because if you keep it under control and you don't let it become very high, that's where we don't want them. We don't want them hyper, because that's when you're going to see the damage in the arterial lumen. Hypertension can lead to atherosclerosis. It's a modifiable factor because it's narrowing that arterial lumen even more, and not only that, it's making the blood become more turbulent to try to get through this constricted lumen with the plaque, as well as it being constricted because of hypertension. And of course, obesity. When you have obesity, you're having to supply multiple areas of the body, a lot of adipose tissue. Smoking, we have a big problem with smoking. Smoking vasoconstricts your blood vessels, right? Because what's in cigarettes that vasoconstricts your blood vessels?
Nicotine?
Yeah, the nicotine, absolutely. And then, of course, if we're a couch potato, sedentary lifestyle is going to increase our risk factors as well for coronary artery disease. And look at this one that says increased serum iron levels. What do you think that means? What's it doing to the blood? That it can make the blood turbulent if I increase my iron levels. What am I making a lot of?
Red blood cells.
Red blood cells. And so what does that make the blood look like?
Thicker.
Yeah, it's going to be thicker, so the viscosity has just increased. So that could cause a problem with blood flow getting through there with the plaque within that lumen, because then it can break it loose. So we worry about that with those patients. So those are your modifiable and non-modifiable risk factors. Pretty much similar, very much similar to your hypertensive factors. All right, so let's look at some of the diagnostics. So you know you're going to do a cholesterol level. So what's a normal cholesterol level? Did anybody get to look any of this up? What do they like your cholesterol to be less than?
Less than 100.
200.
Less than 200. If it's greater than 200, that increases your risk for coronary artery disease. So greater than 200 is going to increase your risk for heart disease. So we like it to be less than 200. All right, so y'all have already told me that the low density lipoproteins, your LDLs, are the bad ones. Where do they like those to be? Does anybody know? Did anybody get to look those up, where they like those to be? Less than what?
130.
Less than 130, but what's desirable?
100.
That's right, less than 100. Very good. Who said that? Was that Shaniqua?
Shaquita.
Shaquita. Why can I not remember your name, Shaquita? That is correct. So the LDLs, which are bad, less than 130, but desirable is less than 100 with your LDLs. The big thing here with this test, when they're doing the cholesterols and the LDLs and the HDLs, they definitely want to make sure that you've been fasting prior to the draw, at least 12 hours, and no alcohol for 24 hours. Where is cholesterol produced? In triglycerides. Where is all this produced? Where is these lipoproteins of LDL and HDL produced? Where are they metabolized?
The liver.
The liver. Right. So if we know the LDLs are bad, then we know that the HDLs are going to be what?
The good ones.
The good ones. And what are they like for that level to be?
Greater than 60.
Greater than 60. There you go. Absolutely. There's one more that will add to a diagnostic test for your cardiovascular disease here, and that'll be triglycerides. Does anybody know what the triglycerides are going to be?
Is it 130?
It's actually less than 150.
Oh, okay.
Yeah, triglycerides would be less than 150. So if you go in and somebody says, okay, we're going to draw blood work for your cholesterol, your LDL, HDL, and your triglycerides. They're looking to see if you have atherosclerosis. They're looking to see if maybe if that is a risk factor for you to develop heart disease later on in life. And like I said, if you do have high cholesterol and high LDLs, they may do, if you're older, they may do that CT scan, that calcium scoring scan as well, especially if you're in there having other problems, like maybe you have hypertension, maybe you've been having chest pain, maybe you've had an MI in the past. Maybe you're in there with palpitations, dysrhythmias. They may go ahead and do a calcium scoring on you just to see what your blood vessels look like. So they could actually do that as well. All right, any questions on any of that so far? So we know what it is. We know it's just plaque buildup, right? And it can break loose and cause a blood clot. And we start making cholesterol when we're born. We don't want it greater than 200. The low density lipoproteins, we want those less than 130, desirable less than 100. And the high density lipoproteins, we want greater than 60. The one thing they do tell people to do with atherosclerosis is they will talk to them about their diet and ask them to go on a low cholesterol diet. Now, when they do that, though, there is not a whole lot of foods that you will be able to eat for low cholesterol. They're going to say, okay, let's go on a low cholesterol, low triglyceride diet. So what kind of meats do you think would actually be on a diet for somebody that's got atherosclerosis? This picture kind of shows you what you need to avoid and what you can have.
Like lean meat, like chicken, turkey.
Yeah, lean meat. Somebody said chicken. That's absolutely right. Anything. So in other words, that means if you want to eat steak, and what makes the steak good when you eat it and cook it? What gives it that taste?
The fat.
The fat. So now we got to cut all the fat off the steak. So it's not going to have as good of a taste. So we really got to learn how to season those things if we want to eat that red meat. We can still eat red meat, but we want to eat it in moderation, correct? And the other thing that has a lot of fat, of course, is going to be pork. That's going to be one of those things we have to be really careful with. What else could we eat besides chicken that doesn't have a lot of fat that's really good for us? It has a lot of omega in it.
Fish.
Yeah, fish, absolutely. Now, I'm going to tell you, a lot of people think turkey is non-fat. Turkey has a lot of fat, believe it or not. So you need to kind of be kind of lean with that moderation with turkey on that one. Eggs. What is the best part of the egg to eat? The yolks or the white?
The white.
The white, absolutely. We can still have egg yolks, but they're going to limit those per week to you. You can still have those. What about fruit?
Yeah, you can increase it. Is it no fresh fruits?
Well, we'd want fresh fruit, right? Because that's best. It doesn't have as much sugar. Now, if we start getting canned or frozen foods, you got to look for that sugar content, right? Because didn't we say that sugar, remember, if a person is really sweet with hyperglycemia, it could affect the arterial lumen. So we'd want to stay away from any of those real sugary and syrupy types of canned fruits. So anything fresh when it comes to food is going to be one of those good things. Vegetables, any vegetable is going to be good for us. Beans, they're saying with beans we should only eat about a half a cup. And nuts, we should be eating about a tablespoon. That's any nut. That's pecans, walnuts, peanuts, because all of those are good for us. They have some good fat in those. What kind of breads do we need to probably eat?
Whole grain.
Whole grain, absolutely, yeah. And usually when it comes to cereal, should we be eating those box cereals like Captain Crunch, Cinnamon Toast Crunch,
No.
Reese's? No, because they got a lot of processed sugar in them. They want us to eat like what? What kind of hot cereal could we have that would be better for us?
Like oatmeal.
Oatmeal, yes. Oatmeal. Yeah, oatmeal. And if you want to eat the other type of cereal, if you can't eat the hot and with the oatmeal and stuff like that, then they say you can have 3/4 of a cup of the other cereal. Just add Cheerios would probably be good. Those are pretty good for you. What kind of milk products do you think this person may want to have on their low cholesterol, low triglyceride diet?
Low fat.
Yeah, they probably want them to do some kind of skim milk. So that means even their yogurts and their cottage cheese, anything that's a dairy product probably needs to be like a very low fat type of cheese, yogurt, those kind of things. When it comes to fats and oils, you're probably going to stay away from the margarines, right? You want to go more to sesame seeds, sunflower, those kind of things. We can have diet sodas. They don't want us to drink regular sodas because they have a lot of sugar. So they want us to stay away from that. If you're going to do fruit juice, you can do real fresh fruit juice. And otherwise, you're going to squeeze your oranges and you're going to squeeze your lemons and those kind of things. Okay? So we kind of looked at that. We definitely want to stay away from snacks like potato chips, those kind of things. Those are not good for us. The biggest thing here when you're on a low cholesterol lowering diet, we definitely want to avoid animal fats and marbled meats. We want to stay away from animal fats and marbled meats. Marbled means there's a lot of fat that runs through it. It's kind of like if you look at a ribeye steak. If you don't know what I'm talking about and you go to the grocery store, go look at the ribeye steaks and you'll see all this white within. That white is actually the marbled fat within that steak. And you will see that sometimes even in ground beef, you will see the marbled. That's what gives it its taste. So we kind of have to stay away from that a little bit. But just remember that the other things with milk products we have to stay away from is ice cream, unless it is low fat ice cream, because it has a lot of sugar and a lot of cholesterol. Does anybody eat duck or goose?
My husband does.
That has a lot of fat, a lot of cholesterol. Guess what else has a lot of cholesterol, but you can eat it in moderation as long as you eat it sparingly, is your shellfish, like your shrimp, your crab, your lobsters. Those you can still eat, but they have a lot of cholesterol, so we only need to eat those in moderation. In other words, don't eat them every night for dinner. So we kind of have to stay away from those. So that's one of the things that they'll do therapeutically for you, is to watch your diet, which we just talked about. And my computer keeps freezing up with this new way of this thing. I don't know why it's doing this. Let me stop. Y'all, my computer is freezing up today. All right, sorry about that. It keeps freezing up for some reason. I don't know what's going on with it today. Well, now I can't find my PowerPoint to share. Won't let me open the tray. Y'all close out your pictures for a minute. That may be what the problem is. I got 4 people on here. See if y'all can close out of the thing for just a minute. It is not letting me in.
I think it's because you just came in as a guest.
Oh, did I come in as a guest? Good God.
Yeah, when you just came back in, you came in as a guest.
All right, I had to turn my computer completely off. I don't know if I've got a virus or what's going on. This is a new computer. I hadn't had it very long. All right. All right, so we talked about their diet. We want them to eat what we call a healthy heart diet, or a heart healthy diet. So that's going to be where they're going to decrease their cholesterol and their triglycerides. So we kind of know what's going to be on that diet a little bit. The other thing we want to make sure it's going to be a lifestyle changing is they need to stop smoking. Because once again, we said smoking does what to the vessels? Constrict, absolutely. It will constrict because of the nicotine. So a big thing we want the patients to do that will help, though, if we have atherosclerosis, is remember I said it's probably not going to show up to about 40 or 50 normally, but it could show up earlier because of the fact that people do start producing cholesterol in their early years, and that they may have a predisposition to the atherosclerosis. And so we may see it develop earlier, so they might end up on this low cholesterol, low diet as well. But the thing is, as you get older and you've been exercising for a while, you may have what we call collateral circulation. Remember I talked a little bit about that last chapter, but collateral circulation is going to be very important as development as you get older in life when it comes to atherosclerosis, because it can protect you. And remember, that's going to be like if you've got a partial occlusion and say you're not getting enough blood flow to that component of the body, maybe it's the heart, maybe it's the legs, it's going to grow these other branches that are going to try to feed that area and give it some more circulation. But is it going to be able to sustain it if there is a complete blockage? Probably not. But while there's a partial blockage and we're growing, I call it a tree branches from the original trunk, we get all these extra tree branches like collateral, then they can sustain that area as long as it's not a complete occlusion. But then again, probably because I have some of that collateral, I may be able to survive a little bit longer than I would if I'm young and I have no collateral whatsoever, because I have some type of blood flow still getting to that component area, either to the leg or to the heart. So those are some of the things we want them to do. Eating the heart healthy diet, which we're going to decrease the cholesterol and the triglycerides. We want to make sure they quit smoking. We want to make sure they're exercising so they develop this collateral circulation. And we need to remember, too, that 2/3 of cholesterol is produced by the liver and in the intestinal tract. So what happens if these things, like if we're not eating correctly, we don't quit smoking, we don't exercise, or maybe we're doing all those things and none of it's working with bringing down our cholesterol levels or our triglycerides, then they're going to add these medications. Then they're going to add us taking our lipid lowering agents. So now you should have your sheet out and ready to talk about some drugs. So we're going to look at these lipid lowering agents, and they are mainly on page 405 in your Med-Surg book, and it's going to talk about medications used to lower your lipids. Also, if you look into your pharmacology book, it's chapter 16, it's on 311. And this one pretty much, when you look at your pharmacology book, you're pretty much just looking for side effects, okay, or any type of contraindications or precautions you're going to use, because there's not a whole lot in this pharmacology book. And remember, when I'm doing side effects, I want to look at something that's affecting someone's organ. Is it affecting the brain? Is it affecting the eyes? Is it affecting the heart? Is it affecting their respiratory status? Does it affect their urinary system? So those are things I'm looking for. Those are important organs that I'm looking at. So the first group I kind of want to talk about that if these lifestyle changes do not work, I want to talk about the drugs that will be used for this patient. So the first one we're going to look at is going to be our bile acid sequestrants. Bile acid sequestrants. I'm pulling up the PowerPoint. So when you think about that bile, what does bile normally do? What does bile do that's released by the liver and stored by the gallbladder?
Emulsify fats.
Yeah, it emulsifies fat. So that should tell you what this bile acid sequestrant's fixing to do. What's it going to prevent us from reabsorbing? If it binds to the bile acids, what do you think it's fixing to prevent? What are we not going to be able to?
Reabsorption of cholesterol.
We're not going to be able to absorb that fat, right? So that's going to be that cholesterol, correct? So we're not going to be able to absorb cholesterol when you see a bile acid sequestrant, because it's not going to, it is actually going to make it insoluble, so we can't absorb it. I'm trying to get to it so y'all can see what I'm talking about here. All right. So we've already talked about these.
Okay.
So we're talking about hyperlipidemia, atherosclerosis, and we're talking about our
and so now we're going to be looking at medications
so they're either going to affect the HDLs, the LDLs, or the very low LDLs.
Angina.
Okay, or triglycerides.
So the first one I want to look
at, I just went to bile acid sequestrants. This is the one I'm talking about.
Are going to be bile acid sequestrants.
So what it's going to do?
So you think
it
about
is going to prevent reabsorption of cholesterol.
Bile
so
is
it
going
becomes
to
insoluble.
help us with absorption of fat.
So
we got to think about that. So what does this drug do? Well, it's going to bind to the bile acids in the intestinal tract, so that we prevent
as well as lower the
LDLs. So what it's actually doing is it's
going to prevent the reabsorption of cholesterol
that cannot be absorbed by the intestine. So it's going to decrease total cholesterol levels, because now the bile is going to be secreted.
Yeah, I can hear y'all.
Feces.
Y'all not hear me?
This is a very safe drug.
Oh, good God.
It's usually administered alone before meals. If you need to take other medications along with the bile acid sequestrant, they should be given 1 hour before or 4 hours after.
Can you hear it now?
No, ma'am. No, ma'am.
What about? Can hear it there?
All right, our next drugs are going to be bile acid sequestrants. So you think about bile. What does bile do?
Yeah, I hear it now.
Okay. The body. Bile is going.
All right. Let me see if I can get the other PowerPoint in here. I'll be glad when we get back on campus. Whew. This is about to wear me out. Because see, I can't tell what you have, what you don't have half the time. What is going on with this stuff? Let's see, PowerPoints.
Speaking of campus, do you know when we're going to get a schedule on how things is going to be set up?
Miss White is working on it, and I'm working on it. It'll probably be coming up pretty shortly. The group that'll be there on March the 29th first.
Okay. I mean, I was just wondering. I'm figuring everybody probably wants to know as soon as possible. I guess for those that really needs to make extra arrangements.
Yeah. Well, I mean, we're doing the best we can do right now on all that, since we had all those meetings last week, so now we're having to do all that to. Let me see if I can open this one up. Let's see if it's got noise on it. Might have to pull another PowerPoint in here.
So will everybody still have to come on the 24th and 25th?
Yes, ma'am.
Okay, because the email just said the 29th.
Yeah, that's because it's not clinical. That's classroom.
Okay.
Yep, clinical, everybody has to be there because the fact that I can't calculate your time and making sure you're doing your work because of the assignments that you're going to have, so you'll have to be there. I think this still has sound on it. I think this is the same one. Yep. All right. So the first one I want to look at is our HMG. And here's our ribomyolysis, where it talks about muscle. All right. Okay. We're going to do it without PowerPoint. So y'all are going to have to bear with me, and then you can go back and listen to the PowerPoints again. Because they're online for you to listen to. All right. So, bile acid sequestrants. Once again, what are they going to prevent the reabsorption of? Cholesterol, right. And they're going to make it very insoluble. So, in other words, that means if it's insoluble, it can't be reabsorbed. Okay? And so when it can't be reabsorbed, where do you think the cholesterol is going to be excreted? Where's it going to go away?
Through the blood.
It's going to be secreted by the stools, right? Through the feces. Okay? So that's the bile acid sequestrant. It's going to bind to the bile acids and prevent the reabsorption of cholesterol. It's going to make it insoluble. When it's insoluble, that means the fat's going to be pooped out. Simple as that. So it's going to be secreted in the feces. That's a bile acid sequestrant. If you want to follow along, it's on 405. And so it's going to decrease the LDLs as well. So it's going to decrease the bad ones, right? Your bad LDLs, your bad lipoproteins. So they're going to go down. This drug is very safe in usage. Side effects, believe it or not, guess what a side effect of this one is if I'm getting rid of a lot of fat? Constipation. Yep, this is one time you get to use that one. Is constipation, because it can cause constipation. So that one is a significant type of problem with this drug, constipation. Now, let's talk about some nursing interventions. Let's think about this. It's very safe to use. We want to give it before meals because we want it in the GI tract so that it will bind with that bile acid when we eat so that we don't absorb the fat, the cholesterol. So we want to make sure we do it before meals. Now, if any other drugs are being given, we should give this drug at least 1 hour before, 1 hour before, or 4 hours after. Because we want those to be able to be absorbed. Now, think about this. We are taking out cholesterol. We are taking out the fat component, right? Because we're binding it to a bile acid sequestrant. So what do you think if we give this drug in high doses that we could actually patient to have a decrease in absorption of, as well as the cholesterol? Because not only are we decreasing cholesterol, we're decreasing the fat. What else is fat? What else is absorbed through the GI tract normally? That you have to have that's fat.
Vitamins.
Yeah, your fat-soluble vitamins, right? So which one of your fat-soluble vitamins are going to decrease in absorption if we give high doses of this bile acid sequestrant?
A, D, K, vitamin K.
A, D, E, and K, yes. Now, let's look at that. All right, we said A, D, E, and K. So what do you think you're going to have to make sure your patient is what are you going to teach your patient to do if we know they're not able to absorb A, D, E, and K? Should they have to take supplements?
Yes. Increase.
Okay. So let's say that if a patient is taking high doses of this bile acid sequestrant and we know they're being depleted of vitamin K, what should they be reporting or if they see it?
Bleeding.
Bleeding, yes. They should watch for the vitamin K deficiency, and that's going to be bleeding. And what might they recognize that's going to occur that may be something simple? What might they do very easily?
Bruise,
right. We may see some bruising. Now, how can we correct this problem and teach our patient besides supplements, what else could they do that would be really simple?
Diet.
Yeah, increase their vitamin K in their diet. Very good. Yeah, we can always increase vitamin K in their diet. So what kind of foods you think they're going to eat?
Spinach.
Yeah.
Any of the green leafy vegetables.
Any of the nice green leafy vegetables, your asparagus, your broccoli, lettuce. Another thing that has a lot of vitamin K in it, unfortunately, is called beef liver. I don't eat liver.
I love it.
But they can do that. Now, because it does not taste good, another thing you want to do as the nurse and tell the patient is to make sure they mix it thoroughly with juice or water. So it needs to be mixed thoroughly with juice or water because it does not taste good. So we want them to do that. Now, I don't think I have contraindications on there, do I?
No, it's just side effects and examples.
Okay. Now, the other thing that I want you to know, though, it will interfere with absorption of certain drugs. And this is going to be very important because these are drugs that you're going to see your patients that have any type of heart disorders they may be on. So this is very important with the bile acid sequestrant. And that's on page 405. And what drugs does it say it can interfere with absorption of?
Digoxin, thiazides, and beta blockers.
Yes, so that's going to be very important that you understand that if you have a patient that is in heart failure and they are also got high cholesterol cholesterol and they're on a bile acid sequestrant, their DIG levels may go down. So they may have to have more DIG. Same thing with the thiazide. The thiazides may not work as well for our patients if they're on a bile acid sequestrant. And same way with the beta blockers. All right. So what is your example of this drug? You only need one. It's the most common one we see.
The cholesterol?
Yeah, the chlorostyramine.
Oh, I don't know.
CHOLES.
Oh, cholesterol.
Yeah, it's the first one, or Questrin. Has everybody got their book out? Is there anybody that does not have their book out that needs me to spell it? If you don't have it out, let me know right now. Okay. All right, so that's one of them. Now let's talk about the one that's the most common in the first line. Which ones are those? Which ones do we normally see prescribed for a patient?
The HMG CoA inhibitors.
Yeah, or the statins, right? They're usually the first line. And so your suffix there will be statins. Now, the thing that Kayla just said, they are also known as HMG, like HMG, the letters, C-O-A, like the letter A for apple, reductase, R-E-D-U-C-T-A-S-E, inhibitors. And that is actually in your pharmacology book because guess what? That is the actual enzyme that produces cholesterol. So they are going to decrease or inhibit the manufacturing or promotion of breakdown of cholesterol. So they're going to inhibit the manufacturing or the promotion of the breakdown of cholesterol. And the cholesterol is made by the HMG CoA reductase inhibitor. And how do you recognize these drugs? It's only called this in your med-surg book. What are they?
Statins.
Statins. Yep. So they're going to inhibit the manufacturing or the promoting breakdown of cholesterol. So when they do that, which ones are they going to decrease the circulation of? The HDLs or the LDLs?
The LDLs?
The LDLs, yep. So we're going to have a decreased cholesterol manufacturing or promoting the breakdown of, okay? It's going to either inhibit them from making the cholesterol or it's going to break it down. And it will remove the LDLs from the circulation. Because the medicine is going to bind and keep that HMG CoA reductase inhibitor, okay, from getting on to the cell receptor. And that is actually called hydromethylglycerol coenzyme A. So we just call it HMG. It's a lot easier. So what do you think is the important time to give this medication? When should you make sure the patient is taking it? When should you give it as the nurse? For most of these, when is the best time?
At night?
Yeah, at evening or night. Why do we normally want the patient to take a pill of this nature at nighttime or in the evening?
Because that's when your body makes cholesterol.
That's right. That is when your body is going to be at its peak production of cholesterol. Very good. Good, good, good. All right. Now, what kind of side effects would we suspect with this statin that's probably going to be reported and the patient is going to be immediately taken off the drug for?
Myalgia.
Yeah, myalgia. Yep. Myalgia. What is that?
Muscle pain.
Muscle pain, absolutely. Because what does the book say it will lead into? Or does it? Yeah, monitor for rhabdomyolysis because that is breakdown of skeletal muscle. So when you have a patient and they call and they said, I'm having severe muscle pain, they're having myalgia. So you want to make sure that you understand that that is skeletal muscle breakdown. That actually can lead into renal disease, renal failure. When they start having this lethal breakdown of skeletal muscle, that's going to be very important. So that myalgia is going to be a very important side effect that we're watching for in these patients. Not all the drugs will do that, but I can tell you the one called Zocor and Crestor are two of the ones that will increase that for these patients. You don't have to remember that. I'm just telling you that in case there's patients or people that you know has been on it and they're not able to take it. Now, the other side effect it can cause is hepatotoxicity. So what would it probably be contraindicated in? Somebody that has what? Liver disease or even elevated liver enzymes. Okay? So this is going to be contraindicated with liver disease or elevated liver enzymes. So tell me, what are you going to monitor besides your cholesterol, your triglycerides, and your lipoproteins such as HDL and LDL? What else should you be monitoring daily?
Your liver enzymes.
Your liver functions test. So you want to write liver functions test, and then beside that, you're going to put your ALTs and your ASTs. So you as the nurse are monitoring for myalgia as well, but we also want the patient to report that. Now my next question is, what kind of juice should they avoid? Because it will X of the lipoprotein.
Grapefruit.
Yeah, very good. Good, y'all learned something. Good job. Y'all done really good with that. All right. So we want them to avoid grapefruit juice, and we want to make sure we don't give it. Antacid should be taken at least 2 hours after. So that's something we want to teach the client as well as we need to know that in case somebody's on an antacid. Should be taken at least 2 hours after. And what's an example that we see a lot of times? You can use any of those that end in statin. I usually do simvastatin or atorvastatin. And there's another one called rosuvastatin. But you're going to recognize it by the suffix of statin. So we're giving that for high cholesterol, high LDLs, because we want to inhibit manufacturing or promote the breakdown of cholesterol and decrease the circulating LDL. So we want their cholesterols less than 200. We want their triglycerides less than 150. And we want their LDLs desirably less than 100, but we'll take 130. No grapefruit juice, no grapefruits. We're going to monitor their liver functions, their ALTs, their ASTs. We would not give it for any liver disease nor elevation of an ALT and an AST. If it causes the myalgia or the muscle pain, it needs to be stopped. So in other words, if a patient calls the doctor's office and says, you know, I've been taking this statin drug and I've been having all this muscle pain, it's stiff, I can't really move very well, you have the authority to tell that patient not to take any more of that medication. Then you are going to let the physician know, because they're probably going to want to order something other than a statin. I can tell you, this is just FYI with statins. A lot of them will help have people take CQ10. Have y'all heard of CQ10? And what they'll do is they'll put them on that for about 2 weeks to try to decrease the muscle stiffness and muscle pain. But sometimes it works and sometimes it doesn't. A lot of people will have problems. But once the patient develops the ribomyolysis, you don't have to remember this, it is permanent. It does not go away. If the ribomyolysis has already occurred from the damage of the skeletal muscle breakdown, that does not get better. But if we catch it early and stop that, then that's better. That's what we want to do with those patients. We don't want them to get to that skeletal muscle breakdown, because they'll always have that problem. But please remember, if they're having the myalgia, they can stop the medication, and it needs to be reported immediately to the healthcare provider that they're having that pain, so the drug can be deceived or stopped. That's going to be very important with those drugs. So once again, this is your statins or your HMG-CoA reductase inhibitors. Myalgia is your side effect. Your suffix is statin. Contraindicated in liver disease or elevated liver enzymes. So you're going to monitor your ALTs, your ASTs. It's going to be given at night, in the evening, because you make more cholesterol at night. Avoid grapefruit juice. Antacids at least 2 hours after. All right. Is everybody with me? Y'all ready to take a little break? Y'all want to take about a 10-minute break and come back at 2?
That would be great. Thank you.
Okay.